Good morning. Thank y'all for attending this webinar. We're going to give it just a couple of seconds so that people can join us, and then we'll get started. All right, well, I think I'll get started. We still have people joining us, but these first couple slides are housekeeping, so I think it's all right. Nobody's going to miss any of the meat of this presentation. So again, good afternoon, everyone. Welcome to today's webinar about food as medicine in practice, and thank you for joining us. My name is Sandra Vandenberg, and I'm a professor in behavioral science and health promotion at UTHealth School of Public Health in Austin. And I'm also the Associate Director of the Michael and Susan Dell Center for Healthy Living. So today's webinar is co-hosted by the Cook's Nook, and you'll hear from Joi in just a little bit. So it's co-hosted by Cook's Nook and the Michael and Susan Dell Center for Healthy Living. The center's vision is healthy children in a healthy world, and we have a mission to advance health and healthy living for children and families through early and impactful interventions, one of which is food as medicine interventions. So I just want to say thank you to the Michael and Susan Dell Foundation for providing funds so that the center can host today's webinar. And then also just wanted to mention that we have information about our center's work and resources, which can be found online. And here's some of the different resources that we have. You can use the QR code on the screen to access those health resources. Also need you to know that the slides for today's recording, for today's webinar, will be archived on both the Cook's Nook website and our website. The Cook's Nook website is cooksnook.net, and our center's website is msdcenter.org. If you have any questions during the presentation, please enter those in the question chat box for the Q&A session at the end of the presentation. We'll be saving a few minutes at the end so that we can answer y'all's questions. And so with that, I'm excited to introduce our moderator and the co-host for today, Joi Chevalier from the Cook's Nook. And Joi, I'll just give it to you.
How about I unmute? So good morning, everybody, and good afternoon, depending on where you are. Thanks, Dr. Vandenberg. Good afternoon. I'm Joi Chevalier, and I am the founder and CEO of the Cook's Nook. I also happen to be the chair of the Austin-Travis County Food Policy Board here in our area where we're located. Our mission at the Cook's Nook is to be the leading developer and distributor of fresh, nutritious, and culturally relevant meals that address food insecurity and chronic disease. We work with our CBOs, municipalities, and innovative healthcare providers to build and implement culturally relevant nutrition interventions into vulnerable communities. And we focus on key populations. Our goal is to help you, your organizations, move the needle in those communities in an impactful way, while also providing dignity and choice. And as we said, you can find our team at cooksnook.net, and we'd love to hear from you. Alrighty, we've got a lot to chat about today with some really, really amazing women that I think the universe of. So I'm going to hand it over to our panelists to introduce themselves for a couple of minutes, and then we'll get into our conversation. This is one of those moments, if you don't know them, get to know them. And so I'm going to hand it over to the great Dr. Elizabeth Polinard.
Thank you so much, Joi. As Joi said, I'm Elizabeth Polinard. I'm an Ascension, Texas nursing professional development practitioner for perinatal services and clinical affiliate faculty at Dell Med in the Women's Health Department. Probably most importantly for the panel today, I am co-developer and program supervisor for Food is the Best Medicine. This is an 8-week food delivery program for postpartum people. And before I tell you a little bit about the program, I too wanted to thank everyone who's responsible for the panel today, and also wanted to say that it's quite a privilege to be a panel with the women that you see before us and our wonderful moderator, Joi. So thank you again. And now a bit about our program. Women who identify as food insecure give birth at Ascension Seton Medical Center, Austin, and live within the 25 zip codes we deliver to are eligible to receive what you see there on your screen. 1 box a week containing 6 nutrient-dense, culturally relevant, and very delicious prepared meals, 4 grain and veggie-forward meal kits, organic produce, and shelf-stable pantry items. Those people who identify as food insecure but are ineligible or decline participating in FBM, as we like to call it, receive a $100 HEB gift card. So in a nutshell, Ascension Seton, specifically the Ascension Texas Council on Racial and Health Equity and the Ascension Seton Foundation, we're able to partner with the very dynamic groups you see there on the slide, Farm Share Austin, the Cook's Nook, and UTHealth Houston at Austin, to create this food access program during the critical 8-week postpartum period. One of the reasons our program has been so successful is because of the collaborative partnerships made between a healthcare system and community and academic organizations. Next slide, please. Our first boxes were delivered in September of 2023, and you can see that in just a little over a year, we have distributed over 350 HEB gift cards, made over 1,372 food deliveries, which is the equivalent of 18,000 meals, including 10,504 pounds worth of produce, delivered to over 150 participants. Additionally, we have 2 grant-funded research projects in progress. Next slide, please. Just a little bit of our story in pictures. Upper right and upper left corners, you'll see actually meals prepared and provided by the Cook's Nook. And then bottom left and right, you'll see the farm share pictures. And in the middle is one of our participants' babies dressed in a onesie that we have provided in the boxes like during the 4th or 6th week of participation. And on that happy note, I will turn it over to Dr. Hollis-Hansen.
Thank you so much, Dr. Polinard. My name is Kelseanna Hollis-Hansen. I'm an assistant professor at the O'Donnell School of Public Health and the Harold C. Simmons Comprehensive Cancer Center at the UT Southwestern Medical Center. I'm also director of the Nutrition Initiatives and Community Health Equity Lab. We have a number of food as medicine projects, so it's hard for me to kind of pick which ones I wanted to focus on with you today. Sorry, I'm getting over a cold, so my voice is a little funny. Hopefully we'll be okay. But the first one is screening for and responding to food insecurity among infusion patients at our Redbird clinic at what is formerly the Redbird Mall in the southern sector of Dallas, Texas. So our patient population here are patients receiving infusion treatment and experiencing food insecurity. We did want to keep it open because we didn't want to kind of pick and choose which patients we would be serving, because a number of patients receiving infusion services need help even if they're not living with cancer, but a majority were over 58%. And in this study, participants received a food pantry referral or a medically tailored meal intervention, similar to what Elizabeth already presented on. Our meals look very similar. And then in our third group, they received a $75 monthly debit card payment. And we encourage participants to use that to purchase groceries or transportation to get groceries. Next slide, please. And the second study it is focused on medically tailored groceries and food resource coaching for patients of a safety net clinic. Want to definitely give a shout out to my MPIs, Dr. Tammy Leonard and Dr. Jacqueline Elbin as well. This study is conducted with, and also the Parkland Health CB Roman Clinic, who are instrumental in conducting this work and give us space and some resources to screen their patients and then also provide support. But These are patients of a safety net clinic with chronic diet-related diseases who are also experiencing food insecurity. In this study, participants are randomized to receive usual pantry services from Crossroads Community Services, which is another organization I want to give a shout out to. So they are a large redistributor on behalf of the North Texas Food Bank, as well as a food pantry that serves between 12,000 and 20,000 households each year in their on-site pantry. And so in this study, actually, and also in the study that I just described, our control group is referred to receive those usual pantry services. Our first intervention group in this study receives medically tailored groceries, which are put together using a majority of the inventory that already exists at Crossroads. And this is a really great way of thinking about moving into long-term translational food as medicine work, because it is leveraging an existing kind of food resource in the community. And then in our intervention 2 group, they receive medically tailored groceries in addition to what we call food resource coaching, which was developed by Dr. Tammy Leonard and Crossroads together. And that is really focused on helping the clients and the patients think about, here are all of my food resources for a month, and here's the best way to kind of manage some of those resources. But it is also very patient or client directed. So whatever is the stressor, or whether that be financial or otherwise in their life, how can we connect them to resources and develop skills to kind of manage some of those things? So that is done in combination with the medically tailored groceries. Next slide. And then this last study is focused on identifying strategies to curtail weight regain after GLP-1 receptor agonist treatment cessation. Very wordy academic language there, but basically this is for patients who are taking GLP-1s, which I'm sure everyone is familiar with. They're a hot topic, so like Ozempic and Wegovy, things like that. When they have to stop, whether because they are ending a research study or they just want to stop the medication, we do see some significant weight regain within the first 4 months after stopping. And so this study is focused on leveraging food as medicine interventions to hopefully help people to maintain some of that weight loss. So our control group is a usual care control, whatever their provider endocrinologist would typically be providing when they stop medication. Our intervention 1 is medically tailored meals. And our intervention 2 is the Noom mobile application, which is like a behavioral science kind of strategy for helping people manage their eating behaviors. And that I just wanted to give you kind of a brief overview of those 3 kind of different projects to set the stage for the panel, and I'll pass it to Dr. Sharma.
Oh, thank you. I was muted by the organizer. Thank you. It's great to share the stage with so many wonderful fellow panelists here. Thank you for inviting me. And it's also exciting to see how much great work is happening in Texas in this space. Really, I'm Shrila Sharma. I'm a professor of epidemiology and director of Center for Health Equity, which is one of the research centers at UTHealth Houston School of Public Health. I'm based in Houston, and just on this slide, just wanted to share a little bit about the center, including some of the work that's happening across policy systems, data analytics, and also interventions, and a part of which is the work in the food as medicine space. Next slide. For the food as medicine space, I think the approach we have used is very much like we're the Switzerland of this work. We bring together partners from the health system and community-based organizations or other food as medicine vendors, and very much using a human-centered design approach, build out partnerships, capacity building, training, technical assistance, and then getting into the actual research and evaluation of this type of work. And it's been a fantastic co-learning experience in really doing this work with our fellow partners in this space. Next slide. One of the work that we actually started with my colleague, Dr. Nalini Ranjit, who's also part of the Dell Center and the School of Public Health, is we did a large-scale evaluation of the food prescription program offered by the Houston Food Bank. This was across 16 health systems in the greater Houston region. And it was one of the first studies in our region that really showed that participation in a food prescription program led to a clinically meaningful decrease in hemoglobin A1C, which is a marker of long-term glucose control. And we also found that dosage mattered. Those who had greater redemptions of these food prescriptions, it was associated with greater improvements in glucose control. This really led to further iteration of our work in regards to food prescriptions. Next slide. So one of the areas of work that we've been engaged in is really thinking about these types of models in high-risk pregnant mothers. In Texas, as we all know, maternal health is a very high priority area for Texas, and a lot of work needs to be done. We also know the importance of nutrition during pregnancy and also postpartum for both the mother and the baby. And so it's important for us to be part of the conversation around food as medicine in this particular group. And so we had 3 cohorts of work that we're doing, testing out different models and really drilling deeper into, what is the dosage needed to move the needle on health outcomes? What does adoption look like in regards to these types of programs? And if there is optimal dosage and adoption, then is it moving the needle on the various outcomes that you see on the very right? So we're working with the managed care organizations like Community Health Choice, Houston Food Bank, About Fresh, which they do medically tailored groceries, and also with Brighter Bites and Planet Harvest, and also Harris Health Systems. And it's, I think, the part that has been particularly important in this space is also looking at the budget impact of these interventions to then inform future cost effectiveness type of analyses. Next slide. And then we have another set of work happening in pediatric populations, especially those who are on Medicaid and at risk for obesity. We're working with UT physicians and Brighter Bites, and also with school-based health clinics. We're working with Legacy FQ8C that run several school-based health clinics here in the Houston region. And school-based health clinics were originally designed to address the medical desert issue. And so really it's been fascinating for us to partner with these school-based health clinics to look at a produce prescription model by leveraging schools as distribution centers for the produce prescription programs as well. So we're testing out that particular model. And then we're looking at how do we also do culinary medicine. I know Kelseanna, Dr. Hollis-Hansen talked a little bit about that in her work with Dr. Albin, but culinary medicine is another approach where that is central to food as medicine as well. And so we are working again with UT Physicians Pediatric Clinic in thinking about a shared medical visit models and testing those out in those clinics. And then we have other work going on that other faculty in the center are leading around culinary medicine in school-based settings as well as dental clinics as well. And you can see the outcomes of interest. I think dental clinics is a whole another area that needs to be tapped into as we think about the role of nutrition and oral health. Next slide. And I wanted to end on, the fact that essentially the picture you see here is of our community advisory group that we've put together in the Houston region. These are all moms with kids of different ages to really help inform the work that we're doing. So very much using a human-centered design approach to inform the design of all of our work, starting all the way from what does a program need to look like to the data that we're collecting. And I just wanted to end on this particular note because ultimately this is the reason why I think we all do what we do, and we have the privilege of serving our communities. So with that, I'll pass it to Dr. Vandenberg.
Yes, thank you, Dr. Sharma. I just wanted to acknowledge here how cool it is to hear about all y'all's projects and how much we're all doing in the space even before this panel. I mean, even though we talk to each other, we're colleagues, but you don't always know exactly what everybody else is doing. So this is really cool. And so I'm just going to kind of piggyback on what Dr. Polinard was talking about, her Food is Best Medicine project, because that's the project that I am involved in terms of the food as medicine space. And I just want to also acknowledge my whole team, Dr. Ranjit, who Dr. Sharma also mentioned. Dr. Ranjit is also part of this project. And then we have some great students who have been just phenomenal working with us. And I just want to especially mention Chris Reyes, because he's really the one that actually started our Food is Best Medicine project. So I just wanted to shout out to him. So as Dr. Polinard explained, Ascension Seton and her work kind of started the whole Food is Best Medicine program. We at UTHealth are conducting the evaluation, but I want to say we're not just conducting the evaluation. We have been partners with Elizabeth and Joi and Andrea for the, from this very start. So even though we are kind of in charge of the evaluation, we're also just really big part of the team. Next slide, please. So I'm not going to go through why we're doing this. Dr. Polinard already mentioned that. We have our partners, which she also mentioned. But what I want to focus on a little bit more here is that, so we have the Food is Best Medicine program, what we call our standard program, which involved the different meals that the women, the postpartum women get for 8-week periods. But then we started thinking about like, well, how, what happens when we stop these deliveries, right? They have home deliveries, it's easy access, blah, blah, blah. But what happens afterwards? So really thinking about sustainability and how can we really change people's behavior so that, the healthier eating continues after we stop the deliveries. So we constructed 2 different enhanced programs, that's what we call it. One involves community health worker visits. So in addition to the food deliveries, the women in this particular treatment group also gets 2 home visits by community health workers. And the purpose of this is to really work with the family or the household to come up with ways to be more resilient to financial stress. Because ultimately, we're talking about food insecure women. It's not only that they need food, right? I mean, the underlying issue is not enough finances, not enough money. And so, it becomes like a toss-up, like, do we pay rent this year? I mean, this week or this month? Do we pay for our medications? Do we pay for transportation, or do we pay for food? And oftentimes food is the one component that you can kind of play with, right? And you can buy cheaper food, and unfortunately cheaper food is also less healthy. So anyway, so we have our community health workers who work with the families. Another part, what they really do is to make sure that those who are eligible for either SNAP or WIC are enrolled. So they will help the women enroll in those programs and any other kind of programs that they're eligible for. Okay, so that's the Food is Best Medicine Community Health Worker Group. And then we also have the virtual Food is Best Medicine Group. And this group, again, gets the 8 weekly food deliveries, but they also have access to a food waste platform, which is actually was developed by the Cook's Nook. And it really provides the same information that the community health workers do, but it's just all virtual. And we really just wanted to see, what is the impact of these different 2 groups, and also what is the cost effectiveness, because community health workers, it does take more time, more resources, but is it as effective? And that is our big study that we are looking at right now. Next slide, please. Okay, so I think at this point I will give it over to Joy. And just a reminder that you can post any questions in the chat box, which is on the right-hand side of your screen.
Thank you, Dr. Vandenberg. Alrighty then. So as you guys said, these are some pretty amazing women who are doing amazing work here in our state, in our area, our region. And so we're going to get right into some of the conversational questions about the work and food as medicine in general. But the first thing I want to tell you guys in the audience is that we're going to do a few poll questions, and we're going to put the first poll question up for you guys. How many food as medicine studies or programs have you been able to lead or your organization has participated in? And so you got your options there. As we jump into the questions, I'll give you a second there to answer that. A lot of us get to do a lot of different work when we think about what is the real intersection with food as medicine and health equity or social determinants of health. How many of you and your organization had the opportunity to participate? All right, thanks for that to our team. I don't know, we can look at the results. There they are. Look at that. So pretty interesting. Most on the call have not been able to participate yet. Hopefully you get to rectify that pretty soon, right? All right, so let me jump into the Q&A here. So what is the role of nutrition, ladies, in managing chronic disease? I mean, yes, we can always sort of say, we all realize that food is important, but what is the real role of nutrition as you guys see it in managing chronic disease? And how have you approached studying this relationship? Because I think people are looking for folks to communicate something about that, right? We have an inherent belief that improved nutrition and food access and nutrition access, I really want to focus on that. We have assumptions about that, but you guys are being asked to prove or demonstrate something. So I'll start with Dr. Sharma and ask her, you know, what is that? How are they seeing that relationship and how would they describe it from the work that's being done?
Yeah, thank you, Joy, for that question. You know, I mean, there's plenty of evidence from rigorous studies that show the positive association between a diet that's high in fruits, vegetables, whole grains, lean protein, minimally processed food, and health outcomes like cancer and cardiovascular health. And then there's also substantial evidence, I think, that shows the negative health impacts of ultra-processed, energy-dense, nutrient-deficient foods on health outcomes. And I think the challenge there is among millions of Americans that are actually food insecure, because those very Americans are the ones that are struggling with these diet-related chronic conditions. And that the reason for that is because if you're on a limited budget, essentially access and affordability of these healthy foods become a challenge. And, you know, we have over 40 million Americans who are food insecure with this chronic lack of access to healthy food.
40 million.
Over 40 million Americans, yeah. And I think the challenge is that they also have concurrently high access to cheap, highly processed food that's high in sodium, refined grains, sugars, unhealthy fats, which over time leads to the higher risk of chronic conditions like heart disease. So it's all intricately linked. And, you know, to answer the second part of your questions, one of the third, I would say the third part of this equation is that consumption of these convenience foods has over time resulted in lower cooking, food prep skills. So people then have, you know, it's sort of a self-perpetuating cycle. That frequency of cooking from home using basic ingredients has also gone down. So it's a vicious cycle that many of our families are engaged in because of the challenge, you know, some of these systemic barriers in regards to being on a financial, you know, distress, if you will, and having lack of access and affordability of healthy foods. And our approach to this, addressing this issue, one of the approaches is this food as medicine space, which is not a new concept. You know, we know that food has been used.
We know inherently, right? We know that inherently, right?
Right. I mean, we know that, and even food as medicine was used back in the AIDS epidemic, to address, provide nutrition and social support among those with HIV and AIDS who were stigmatized at the time. And now I think we're in this space because of working with health systems to identify those who are at highest risk for these chronic conditions and really provide them with the tools, addressing health, because health is not just the absence of disease, addressing health and well-being by providing them with access to these healthy foods really helps achieve, the maximal impact, even when it comes to medical management of chronic conditions. And so that's the approach that we've been using with Food is Medicine, is bringing these partnerships together to target the very communities and populations that need it the most, and bringing these healthy foods into the hands of these households that are struggling the most with these chronic conditions. So I'll stop there.
No, thank you, because I know we got a lot of questions, and my goodness, you ought to see the Q&A. There are questions over there. So I'll jump and let Sandra, or say Sandra, you guys know we know each other by first name, but Dr. Vandenberg or Dr. Hollis-Hansen also come in and sort of think about that. How have you approached trying to demonstrate this? Ooh,
You're
Dr.
muted.
Vandenberg, you.
Sorry.
Sorry.
I just, yeah, everything that Dr. Sharma just said, I mean, it's just so good, right? I mean, I think inherently we know, but all these big studies over and over show the positive impact of healthy eating, which includes fruits and vegetables and, minimally processed foods, whole grains, etc. So we know what we need to eat. The problem is, one, it's expensive, right? I mean, I think that is probably, if you look overall, that is the #1 barrier to eating healthy. Transportation, so physical access, and the lack of cooking skills, again, that Dr. Sharma mentioned. It keeps on coming up in our qualitative data that we collect, in terms of, when we ask people why don't they eat,
Right.
Anyway. So the culinary arts, I think, is such an important aspect of even, what we're doing, even though we're providing access to food, etc. But that culinary part is really important too. So providing access to the skills needed to prepare those foods.
So you guys keep coming back, and I'm gonna jump to you, Kelseanna. Gosh, Kelseanna. I'm just gonna call you by your first names because that's the habit. Sorry, guys.
Please do. You can call me Kelseanna.
Okay, thank you. You guys all talk about, and if you look back at each of your sort of the work that you're doing, behavioral change, social support is part of this sort of requirement, along with the nutrition and the access itself. So Kelseanna, I'll let you go ahead if you want to come to that as well.
Yeah, interesting. I'm a big fan of study design in particular, so I took this question in that direction in my planned answer. But I will speak to what you just brought up first, which is that I think these kind of multi-component interventions that do address all different social determinants of health that we know impact nutrition and chronic disease outcomes is imperative. And, I think we're at the start, but what I hope we see as we move further, and this is actually kind of my response to one of our later questions, but is this kind of whole food systems thought process about food as medicine that can address, things like supporting agriculture for farmers and reducing waste in the food system, while also providing this direct access to more nutritious options and other supportive components. So we call that, multi-component interventions. When I was thinking about like how have I approached studying this, I took this as like researcher hat. So
I know that's fine. I was doing researcher hat too.
Yeah. Well, and because I don't really know who's on the call, right? And so like we all have different levels of understanding of like the research process and study design process. But, I wanted to talk about even things like just that there's several ways of studying this relationship, and there are just different pros and cons to all of them. So you can conduct what are called observational studies. These are like cross-sectional studies where people measure nutrition and eating behaviors and chronic disease outcomes at one point in time. You can do cohort studies, which look at people over time, looking at what they're eating over time and how that impacts their chronic disease outcomes over time. Or you can do experimental studies where you randomly assign participants to receive different diets or food as medicine interventions or different types of food and measures, and then look at that change in outcome over time. And so most of my work, to actually directly answer the question, focuses on the latter. So randomized controlled trials, which are a type of experiment where people are randomly assigned to receive the different food as medicine programs. And then we look at those changes in outcomes over time. And I think based on what I heard of the collaborators and what I know of their work, I think a lot of their work also focuses on the randomized controlled trials or evaluation of programs that are already being implemented. And there's a number of different pros and cons of doing those. And I just mentioned that because we don't know, I don't know who's on the call. So that might be information that you don't necessarily have already. Yeah.
That absolutely makes sense. And you can have a whole nother conversation on, if you're looking at food as medicine, why do you choose, different variants? And you guys will excuse me as not being a researcher in that way. Why you choose different kinds of designs, and what is the benefit plus minus of any of those kinds of designs in particular communities. And I'm just going to ask a question just sort of related that someone has asked. Was there any in any of your programs significant participation enrollment hesitancy, and why, as part of that conversation? Elizabeth, do you have any particular thoughts? This is a general Q&A question, or any of you guys jump in where you see that hesitancy. You're muted, Elizabeth. No, you're still muted. Oops. Okay, well, I'm going to move on. We'll figure out how to get you unmuted. One of you other guys want to jump in real quick?
Yeah, it's funny you asked that question because we actually, of our mom community advisory group, we brought this up recently, and one of the key intangibles was trust. And trust with the health system, with the providers, and with what service is being provided to them. And part of that trust was also communication and dignity of communication and how that information was provided to them. And so that's an intangible in terms of, but very critical sort of, first impression makes the lasting impression. Yeah. Very critical in terms of providing that dignity in terms of communication and enrollment into these sorts of programs is critical.
Thanks for that. I'm going to move on because, gosh, we had several questions here. Let's come to outcomes. How do you measure the outcomes and success of these nutrition-based interventions in patient care? And I'll start with Sandra. Are we all muted?
I'm not.
Okay. I just got unmuted. Thank you.
Okay, yeah.
So to go back to the question is, how do you measure outcomes and success of these interventions in patient care? And you realize, Joi, that this question could be like a whole course.
Oh, yeah.
But so before I answer it, I just wanted to mention real quick again, also because I'm not sure about the audience either, and just so that people are aware, there are different food as medicine types of interventions, right? We have the produce prescriptions, we have healthy food prescriptions, we have medically tailored groceries, we have non-tailored meals, we have medically tailored meals. So there are different ways or the different types of programs. And I think depending on what type of program you're implementing is what kind of outcome you're looking for, right? Because not all outcomes would be necessarily would make sense for certain interventions. But if you look at the whole range, and I did a quick lit review of food as medicine interventions that are currently, being conducted. And you really have a range of outcomes. So you have some that, people or studies that are looking at clinical health outcomes, such as biomarkers, HbA1c, or people are looking at hypertension, cholesterol levels, BMI, medication usage. So really more at the clinic level. And then you have studies that really their main outcomes are looking at the nutritional outcomes, so dietary intake patterns, quality of diet, etc. Then other studies that focus really on food insecurity or food security may be their main outcome. Then we have outcomes such as behavioral outcomes, such as meal planning, cooking. How often are you cooking at home? Some studies look at quality of life. Some studies look at mental health, and that's actually one of, I think, in our study, Food is Best Medicine, where we're seeing the most significant outcomes or differences are in the mental health status of the postpartum women. And then not most
incredibly important, Sandra, is thinking about depression rates and things. I think, sure.
And of course, especially when you're working with food insecurity, I mean, that has a lot of stress, right? I could imagine, people are worried, they're stressed. So it's not surprising that we find high rates of depression in these types of households. I also want to say economic outcomes are very important, because if we really want to make a case that these types of programs need to be institutionalized, and being paid for maybe by health insurance, then we need to make sure to show that they're cost effective. So it's really important to measure the cost. And then lastly, I also want to say,
not just the cost effectiveness of the program, but also potentially the return of investment and return ROI to the partner. That can be more of a challenge, to be honest, sometimes, depending on whether that is shared with another organization or healthcare organization.
Exactly. Yes. And I also want to just mention, not only is it really important to look at outcomes, we also need to collect process data. And Dr. Sharma mentioned that a little bit, like we need to know what is the right dosage, right? What is the right way to implement? What is, there's so many questions that will affect implementation that we really don't know yet. I think this whole field is still just starting. And so really almost the process data is as important, if not more important, than the outcomes data, because we need to know how to do this. And we don't really know that yet. And I think that's what was kind of really interesting, listening to all the different projects that are just the four of us were talking about, because everyone is a little different. They're different lengths of time, different populations, etc. So really important to collect the process data as well.
No, that's pretty important. I think that's pretty evident just in that you guys' presentation of each of your work, just these vectors that are in these very specific places and communities with its design, with everything that's about each of the programs, right? So I'm going to go on to quick question. We're going to toss up another quick poll, and I'm going to go on to the next question because I know I'm just mindful of time here with us today. If our team could toss up that poll, that'll be fantastic. For those of you guys who have done programs, how have they led to a change in how your organization delivers services or become part of standard care? That is, have you gotten to a point with any of your programs or versions where it's been integrated into standard care I like what you said, it's institutionalized, as becoming part of routine care for clients and patients. I'm going to give you guys another couple seconds to answer that. And then we will probably show you a response there, which is amazing. That's more than I would have expected. That's awesome. You guys see that 35%. That's pretty impressive, especially in these early days of food as medicine, as many of you guys know. All right, let me move on to the next question here, because I think we're already going there. Is a lot of you guys are with organizations and institutions that are, sit at amazing tables, have access. How do you work with policymakers or your teams, your organizations work with policymakers, or you individually, to promote the inclusion of food-based solutions in public health programs? How do you then put that into, let's say, policy, at least, if not yet into practice?
Yeah, so I think for me, well, first, many of us are at state of Texas institutions, so a lot of our advocacy work actually does have to be done separately from kind of our university-related affiliations. So personally, I'm involved with a number of nonprofit organizations that have a focus on nonpartisan food as medicine-related advocacy. So for example, this can include advocating for our state to participate in those Medicaid and Medicare waivers, Section 1115 waivers and Section 1915B waivers, which provide reimbursement to patients that have Medicare and Medicaid for food as medicine interventions as a part of their treatment program. So that's a big way that we can kind of move this from kind of studies to policy and practice. I also I have to, because it's who I am, but I have to bring this up even though it's not directly related to some of the things we've been talking about, but I really advocate for our state to participate in sunbucks. So sunbucks are those additional women's, infants, and children, or WIC benefits for families participating in WIC over the summer. WIC is really one of our first food as medicine programs in the United States, and it has been consistently shown to improve family health outcomes in a number of ways. So that's a huge part of my food as medicine related advocacy. And then I also really prioritize speaking publicly about the opportunities of food as medicine in several settings, including in non-academic settings and events that are more likely to reach people in government or people in industry that maybe have more ability to move those policies and practices forward. And so one example is locally I'm involved in a Dallas food plan working group, and will hopefully include things like the expansion of food assistance solutions and food as medicine initiatives as a part of that plan.
You mentioned the Dallas food plan. You mentioned the Dallas food plan, and I'm going to toss out that Austin in Travis County just passed its first food plan this past week, which we are incredibly excited about here as well. And major cities need to have these frameworks of how they want to address with some of the ecosystem things that you guys have all addressed, not all the way back from farm, all the way to potential waste, which is pretty amazing. Sorry about that, Kelseanna. I didn't mean to catch up on the food plan.
Yeah, I've lived in Travis County and equally as happy about the Travis County food plan, and the city and the county did amazing work on that, and all of the community members. They surveyed, I think, like 4,000 or listened to almost 4,000 community members. So really, they deserve their kudos for sure.
Yeah. Who else wants to jump in here just about policy? I'm sure, Sheila, you spend a lot of time on policy questions.
Sure, I can just add, I'm just love everything that Kelseanna just shared as well. And I'm jealous of the food plans that y'all have. But just, yeah, I think one is using our data to inform the conversations. And so, you know, the Dell Center has the Texas Research to Policy Collaborative, and we've, I think, all at some point been part of the, one-pagers that have been developed as part of the Research to Policy Collaborative to inform legislators in regards to what does the evidence look like, right? So building sound legislation on the evidence. And then another space I'll just highlight is in Houston, we actually 6 years ago launched the Health Equity Collective, which is a systems coalition in the greater Houston region that brings together health systems, community organizations, academic institutions, and government institutions to really think about these non-medical drivers of health. And in that, we have a very, very active policy work group that has been working very closely with local and statewide stakeholders in building and informing policy agendas. And I think that's really powerful because it's using collective impact, right? The voice of many organizations and systems is always going to be powerful than one. And so using very much that collective impact approach to inform legislative priorities in the state is one of the areas of work. And food as medicine is one of the policy agendas in that space as well that the work group has focused on.
Before we go on, I'm just gonna, if you're unmuted, if they got you unmuted, looks green up there.
I'm unmuted.
Okay, awesome. Can you just, just sort of policy work that you guys may be doing, and also from a corporate perspective as well?
I can speak from a perspective of working in a healthcare system, right? Ascension has joined public policy initiatives like the White House Challenge to end hunger and build healthy communities. And they did so which will allow us to help inform policymakers and also stay engaged at the highest levels. I also feel like, just speaking from my own fairly limited personal experience, that collaboration between a healthcare system such as ours and our community partners to develop these programs, it helps us present a united front and a collective voice. And we are doing things now, primarily thanks to Sandra and her team, like having lunch and learns and possibly even panels with legislators to help keep them informed of the initiatives in front of them.
No, thanks. Sandra, you want to toss anything there before I jump on and bring up the next poll?
Let's go to the next one. I was going to talk about the Research to Policy Network, but Shrita already discussed that a little bit. So I think it's probably better to go to the next question.
Okay, awesome. So people have asked, I'm looking at some of the Q&As and making sure that some of their comments with the questions that we have addressed your questions, but several people have asked this question already in Q&A. Where have you received funding for any of your research or programming? And if you have and are trying to select the various one or more of the following, if you can. There's just lots of different things that are happening right now. But a question always comes back, how do you afford to do that? And then I think someone even asked, how do you even get started? Which we'll get to here in a moment. So just another couple seconds on the poll, and then we'll toss the responses up. You guys are going, oh my gosh, it's fast. Well, we only got 8 minutes left, so I want to make sure. Now, that is amazing right there. If you're lucky enough to have one of the large multi-year federal grants, kudos to you. But what's fascinating is how much work and how many dollars are actually being driven to try to understand food as medicine from nonprofit organizations, CBOs, and through private foundations before it becomes institutionalized. And I think that's a challenge. I think we're finding that a lot of organizations who are the smallest and least able to afford it are some of the ones, and even in private foundations, are some of the ones who are driving a good chunk of this work right now. So, all right then, let's move on here. Guys, I may skip one of the questions we're going to talk about, let's go to clinical care and just sort of say, okay, we've talked about policy. Well, how do you translate that into actual patient-client engagements and actual, I would say clinical, even non-clinical care and engagement. So, and this comes back to, how do your programs actually reach and access and get people in, and to that trust question as well. So, you guys want to jump in first? And we're going to take just a couple of minutes for this, and then we want to get to last question and Q&A real quick. So, jump in. Okay, not all at one time.
Joi, could you repeat the question? I'm not sure. It seemed like we did a couple together. So if you would mind repeating, that would be great.
No problem. What are the biggest challenges in then translating food as medicine research into practical applications in care, on the ground care? How do you actually touch people, clinical or non-clinical patient and client engagement in care?
I don't mind getting us started if that's okay. Because I feel like this is sort of the money question, right? Like, hands down, one of the biggest challenges is the time that it takes to translate research into practice. In my nursing research class, one of the first questions I ask is, how long do you think that takes? And I get everything from 2 months to 20 years. And the last statistic I saw, it put us between 10 and 20 years to actually translate research into practice. I'm really expecting that will change with as we continue to progress with AI. Of course, we'll have to be judicious, right, in our use and everything. But another recommendation that I had was to maybe, while you're waiting for research to be translated into practice, that you actually just start an initiative at your site or within your network, or you join an already established initiative. You can use what has been done to justify the work and to build on it. And though I'm not necessarily volunteering any of my colleagues on the panel, I'm sure any one of us would be happy to connect with you to discuss our programs and how you might be able to implement something similar, and inform your leadership, including your C-suites, about your initiative so they can help support its implementation and sustainability. These are the kinds of really good service-oriented programs that others feel good about and with which they would like to be associated. And finally, for me, before I pass the mic, I'd also like us to consider how important it is to translate our research findings for the lay community, right? Both those that have been studied and those that are affected by or can resonate with our findings. It's crucial that we allow our communities to have a say. It should be the majority of the say in how best to meet their own needs. I'll pass the
Thanks
mic.
for that. Yeah, go ahead, and one of you other guys, if you like. Practical applications. I mean, you probably just explained it. It takes time.
Yeah, and I was going to speak to a little bit I have several, I'm not a clinician, but I have several clinical collaborators and friends, and just many of them are so exhausted and overextended. We've seen a number of papers come out, especially since the COVID pandemic, on like healthcare worker burnout, for example. So it's hard to, I think, consider adding another thing or multiple things to their clinical workflow when patients and providers already report feeling unsatisfied with like the amount of time they get to spend together, for example. So I think this is where more investment in the dietetics and social work and public health workforce, Dr. Vandenberg and Dr. Sharma both mentioned community health workers. These are roles that can really help to fill that gap on the screening and referral piece in the clinical setting. And I just want to put out the reminder that the healthcare organization does not need to be the organization that's actually providing the food, right? We can partner with these existing food retailers or food assistance organizations to help them improve their funding resources and not have to take on any of that burden ourselves. So that kind of collaboration is really important. And then I think another major challenge is just at this minute, lack of consistent funding. But I hope that'll change soon with those Medicare and Medicaid waivers and other and private insurers considering or already investing into food as medicine programs as a covered benefit. And then just thinking creatively about other ways to fund these programs long term.
Yeah, no, that makes sense. I'm going to skip one up. Well, let me just go ahead and toss it out there. We only have a couple of minutes left, you guys, and I'm sorry if we didn't get to all your questions. Tried to embed them a little bit into our conversations. Lastly, what do you see as the future of food as medicine in clinical care? Where do you see some promise? Where do you see next step? What do you see next phase? Or what is still, we are still in early stages of this, but what's the next part? I will toss in is your increasing partnerships and reliance on your what's the word I'm looking for? I don't want to say for profit, but your partners in business and in the marketplace to come in and join in this. And there's reason to do that. And an essential reason to do that. And you're going to find a lot of organizations like mine, I'll just say honestly, who are really focused and have a mission in these communities for folks to partner with. And I think you'll see a lot of market organizations deciding to partner in these spaces to advance them. And it's going to be necessary to advance them because they have the dollars, budget, expertise, operations, logistics to be able to make programs real, long-term, and sustainable. So anybody else, what do you think is part of the future of this?
So I think it's really important that we consider, like, we can figure out how to make this most sustainable, right? Again, we probably cannot provide food to everybody who's food insecure for the rest of their lives. But so what can we do? What kind of skills can we teach? How can we set this family up so that they could take care of themselves financially, including buying healthy food?
Yeah. So you change the mindset in the household. Go ahead, Shreel. I'm sorry.
I was just going to say ditto and ditto, and I'll just add that we want to be in a world where healthy food is a covered medical benefit, and that's because when you have a patient who is diabetic, their meal management is as important as their medicine management. And so as we know, as we think about the burden of diet-related chronic conditions, which is not trivial, and with healthcare costs exceeding $4 trillion a year, some of those dollars need to be invested in these types of strategies where healthy food is a covered medical benefit under our insurance plans. We all need it, and it's not just a problem of the poor. I will say the good news is that there's plenty of expertise right on this panel and around the state and the country who are willing and able to partner to help build those types of strategies within health systems and health plans. And so we're here open, willing to help and partner in making this happen.
No, thank you guys. We are so out of time. I'm going to ask the team to go up to the information slide so you know how to reach everybody. You guys already know what I think of you. You're some of the most amazing women who are moving this space forward, and professionals, and appreciate you and all of your work you're doing around our region, our state. If you guys notice, this is Austin, Dallas, Houston, but it's the same wherever you're located. There's a lot to move these systems forward. Reach out to us. We're more than happy to discuss a variety of these things with you. There were a lot of questions on the nutrition itself, and I'll just toss out there, following many of the USDA guidelines, but also the individual medical industry guidelines on diabetes, renal, and heart health is actually a part of that. Happy to talk to you about that separately. But any of these guys will be able to, would be more than happy to talk about the programming and the work and how you can get started in creating a program that you need to create. So thank you so much for joining us today. Thank you for all of your questions. Thank you for your work that you're already doing in this arena. Check out the QR code to find more about the Michael and Susan Dell Center for Healthy Living, which is an amazing organization. And you can find all of us online. So thank you so much, you guys. Have a wonderful afternoon and rest of your week.
Thank you so much.
Thank you.
Thank you.